Hi, this is Janet Powers. I'm Senior Director of Analytics at Eliza. So we know that plans are really focused on increasing their risk, increasing their quality scores, and reducing costs. In order to do that, you need to improve your outcomes. And in order to improve your outcomes, you really need to motivate members to take some action. The best way to do that is to really understand your members and know what makes them tick. At Eliza, we have a lot of data that others have as well. We have health care claims data, medical claims, pharmacy claims, eligibility data. We've got consumer data, census. One thing that we have that a lot of others don't have is self-reported data that we're collecting in our engagement outreach. And this is really the gold. We've been at this for a long time, 15 plus years, so we've been able to look back and compare this self-reported data with outcomes to really understand what pieces of these self-reported data are really driving the outcomes, which pieces really matter. So, social determinants of health is a big issue. A lot of people are talking about it, and where we are as well. The real takeaway from this slide is no claims doesn't necessarily mean good health. Life might just be getting in the way and crowding out someone's ability to take care of their health and go get their preventive screenings, for example. On the flip side, claims don't necessarily mean bad health. We want people to utilize care in the way that they should. The other thing that we'll talk about a little bit is someone's self-perception of their health. That might impact how they utilize care, and we'll talk about that in a few slides. So what do we know? This isn't an exhaustive list. We ask other things like intent to take action. We ask HRA survey questions. We do proxy, HOS, and CAP surveys. So we're collecting a lot of other information. For today, we're going to focus on these types of questions. So we know things like self-reported overall health. In the past month, how is your overall health? In the past year, how would you say your physical or emotional health is trending? Is it getting better? Is it getting worse? And then any emotional issues or physical health issues, are they affecting your ability to function in life, whether at work or at home? And then barriers, discomfort. Say you're trying to get someone to get a mammogram or a colon cancer screening. Discomfort can be a big barrier. Transportation, if you can't get to your appointments, it's hard to follow up. Side effects, this is a big issue with medication adherence, cost, and then something that's sort of simple is having a doctor or having a doctor you work well with. If you don't have that, then it's hard for you to take that next step and get your care. Also, we ask questions related to social determinants of health, like do you have a place to live? Do you have enough to eat? Do you feel safe? And why does it matter? Well, if you have some of the issues on the left, then your HEDIS rates are going to be lower. Your gap closure rates are going to be lower. Your future costs will be higher because you are letting things escalate until they come to a tipping point, and then your medical costs are going to be higher in the future. And also suboptimal resource deployment. So health plans have a limited pool of resources, and we want to make sure that they're using those resources for the people who really need them and not potentially wasting any resources on people who might have taken that action anyway. The magnitude and impact of these issues is pretty great. So we've got 14 to 47% of people saying, yes, I do have this issue, whether it's about their health status, their trends in health, the impact of poor physical health or poor emotional health and their ability to function, the barriers we just talked about, or the social determinants of health-related issues. So 14 to 47% of people are saying, yes, I have this issue. And that matters. When you look at people who have the issue, their HEDIS gap closure rates are between 5 and 30% lower than those people who don't have those issues. So it's having a big impact on HEDIS gap closure rates. Also, 44 to 54% of people are reporting that poor emotional or physical health is impacting their ability to function at home or function at work. So these people need help. We can't expect them to go and manage their care easily unless we give them a little help to get over these hurdles. The questions that we ask are often related, and this will make sense. The relationship between having a concern for life necessities, a place to live, having enough food to eat, feeling safe, there's a relationship there between that and a self-reported overall health status. So as you might expect, as your self-reporting of health status goes down, as you report worse and worse health status, the concern for life necessities goes up. So there's a relationship between these two questions. We'll talk a little bit later about how these translate to costs and future costs as well. So then, knowing what to do with the information, Eliza uses everything that it knows to design outreaches to get people to take action, right? We know things like clinical propensity scores. We know channel receptivity scores. How likely are you to respond to one channel versus another? We can use personas to talk to people in a way that it will motivate them to act based on what we know about that person. We collect permissions and opt-ins to use the various channels, and we design these campaigns again to drive behavior change. What we also do is partner with our clients to make sure that we're best using their resources. So if a health plan has care management, for example, we might direct people to care management who tell us that their health is declining, or they are worried about life's necessities, or they have some side effects, like they're worried about discomfort or medication side effects or costs for barriers. We also can transfer people to a live agent. Say someone doesn't have a doctor or they need to schedule an appointment on an IVR call, we can transfer them to a live agent right then and there in the moment that can step them through the process and connect them with a doctor and help them schedule an appointment. There's online tools that are available. So if we know someone is tech savvy, we can point them to things like the DocFind tools online or wellness program online, or there's a long list of things that we can point them to. And then finally, if we know someone has transportation barriers or cost issues, we might connect those people to any kind of mobile resources or transportation vouchers or even incentives. And the good news is it works. In one case study, we had 5 out of 5 targeted STAR measures show a year-over-year increase after the Eliza outreach. And we also moved these measures to the next STAR threshold. We're shifting those who were non-compliant in year 1 to a closed status, a compliant status in year 2. So 19 to 20% of those who had a breast cancer screening and a colon cancer screening gap in year 1, we were able to move them to closed status in year 2. We're reducing hospital readmission rates, improving retention, and another interesting finding is when people are reporting these social determinants of health related issues and we transfer them, when we ask these same people in the next year, they're less likely to report that issue. So what's happening on the other end of the phone line when we transfer them is working to reduce the rate of someone responding that they still have that issue. And like everyone, we try to be able to forecast the future versus just reacting to what's happened in the moment or what's happened in the past. So here's a slide that shows a relationship between overall health, the self-reported overall health, and cost and risk. So like we showed before, the blue line is the current year, the green line is the future year. You can see that as the overall health status goes from excellent to poor, the cost and the risk score goes up, and that's in the current year in the blue as well as in the subsequent year in the green. The interesting thing here is when we take out the morbidity factor, so we adjust based on that risk score, we still see that lift as you report more poor overall health, cost goes up in the current year and in the future year. So we're digging more into this, but we're thinking a couple of things, a couple of hypotheses we have are we picking up something that the risk score isn't picking up? These things aren't all encompassing, so maybe we're identifying something that the risk score isn't, or is it something about the self-perception of health where if people feel like they have poor health, they're utilizing resources maybe in excess of what they need to be using. So we're maybe looking at overutilization issue. So we're going to dig more into this, so more to come on this, but a really interesting finding. So overall, the self-reported data that we're collecting is helping to achieve that triple aim. It's helping to improve the patient experience, it's helping to improve population health, and it's helping to reduce overall costs.